Yeah, thank you very much. 6 talks in a row is probably a long time, and it's me just that keeps you from the coffee break. So I try to make this as interesting as possible and also as quick as possible. I think coagulation in the context of ischemic stroke is an important topic, should be in the front of such a meeting like this one, because it's a fundamental underlying principle that need to be addressed, and where some of the concepts should be actually understood and addressed for all the further discussion of how stroke actually develops. I have no implication with regard to this presentation, however, some disclosures. You had this information already in a previous talk, that there is a diversity in the etiology for stroke. It's not so easy going like in myocardial infarction, but the majority of the strokes are ischemic in nature, like 85%, whereas only a small fraction refers to hemorrhagic stroke. And for all of these ischemic strokes, actually coagulation plays a major role, be it within plug rupture, where an embolic development is putting on top on the local position of the embolization, or being an embolus that has been built further upstream in the heart, maybe even in the peripheral vascular circulation, and then transported to the brain and blocking then in the brain the vessel, so causing as well as an ischemic stroke. By contrast, hemorrhagic stroke is by bleeding of a weak spot, and a typical weak spot can you see here, that is an aneurysm that may rest for decades without any problem, but with some hypertension or some sudden pressure increase, this may rupture, and you have then this intracranial bleeding. If we look at the ischemic stroke and some subtypes of this, then you see what the neurologists usually use here is the TOAST classification. Again, 85%, and it's by etiology subdivided in these 5 major areas. The cardioembolic, it's self-explaining what the etiology here is. Large artery strokes forming atherosclerosis. Small arteries where this intracranial increase in the wall vessel thickness, and in some stage the vessel is just so thick, the vessel wall is just so thick that it is blocking further conduction of blood, and it leads to small emboli with lacunes. Then there is a certain field of undetermined, formerly called cryptogenic stroke, but cryptogenic means basically we don't know what it is, so it's a bad diagnosis saying we don't know what it is. Therefore, the new concept of ESOS, embolic stroke of unknown source, has been developed. And of course, there is still a subgroup of very rare aspects. And if you look at coagulation now in this context, then you see coagulation plays a role in each of these etiological fields. So it's really worth to spend some time on the coagulation. And don't worry, I'm not going to bore you with all this, what everybody of us has seen in med school for quite some time, and we all tried to learn this and to understand this, and probably most of this is of course kept in our brain, but I'm not going to these cascades in detail, and I'm not going to make it even more complicated to give you the broader picture of integrated coagulation and repair mechanisms. Although of course by the decades of research and clinical investigations we have a very thorough knowledge of these mechanisms. However, in our clinical setting, we may not need this. In our clinical setting, we may need to go to some very basic principle understanding. And this principle basic understanding has been proposed for the first time already some years ago, like 1850s, from Rudolf Virchow, who's also the name of the hospital where I come from. And he proposed the major trias for coagulation, for control of coagulation. That is the balance between blood flow, the vessel wall, and the blood-borne factors. So he called it viscosity. So these 3 major factors actually contribute to keeping the blood fluid, or if any of these factors is somehow abnormally controlled, then there's an imbalance here and coagulation actually occurs. And of course, those aspects lead abnormalities in these three aspects of this Virchow trias lead to complications, where rheology, there is a diversion from the normal anatomical bloodstream, leads to some turbulences, and this immediately makes some agitation to the blood-borne factors and causing some coagulation. So by nature, the blood flows through the vessel system and even through the complicated heart anatomy is really developed so to let the blood flow through very smoothly. And if there's any pathological abnormality like congenital heart disease or mechanical obstacle, then there is a distortion of the laminar flow leading to impairment of rheology. Hypercoagulability does not only mean an activation of the anticoagulant system that we have seen in a cascade before, but it also means that any other kind of cytokines of inflammatory activation may actually be an obstacle or a problem to increase coagulability of this blood. And for instance, in heart failure, even if we have no problems with the coagulation cascade, there is a constant hypercoagulability due to the increased inflammatory activation that we know is present in all heart failure patients. And endothelial injury does not only mean an mechanical damage like a cut or like a bruise, it also means that endothelial dysfunction, which is again a cornerstone of pathophysiology in all cardiac diseases, may actually already lead to some activation of the surface, of the inner surface of these vessels. So all these three have plenty of possibilities to go wrong, leading to this protrombotic state that already Rudolf Virchow suggested some 100 years ago. And if you keep these three factors in mind, then you will easily think about any given cardiac pathology, and you will identify at least one, probably all three of them, being complicated. It may be with abnormal kinetics, with abnormal blood flow, with abnormal conductance between the cavies, and also with inflammation. I mentioned this before. So any cardiovascular pathology leads to an abnormal imbalance between these three factors, leading to an increased risk of coagulation. With regard to total volume of contribution of clinical issues, you see here that the overwhelming majority of cases actually comes from atrial fibrillation, clearly the front runner of making trouble with regard to coagulation, but there is another fifth of the events, of the cardioembolic events, coming from ventricular thrombus, and another 30% then from valvular heart disease or other structural defects of the myocardium. Now, what can we do actually to identify those patients at bigger risk? What are the biomarkers, the measurements that we have in our hands on the clinical everyday life or everyday work to identify, ideally even in a quantitative manner, those patients we need to have special eye on and special attention. In general, you can subdivide this by laboratory biomarkers, echocardiography biomarkers. There is some rhythm aspects, of course, the big one with atrial fibrillation, and clinical scoring. And I will address all these in the next few minutes in a little bit more detail. With regard to lab parameters, biomarkers that you can measure, of course, there's a multitude of markers that can be measured in the bloodstream, and all of those have been investigated and have shown to have some implication with regard to increased coagulability. Do we use them in the clinical everyday work? Probably not. If there has been testing of what would be predictive with regard to stroke occurrence, so looking into patients who suffered a stroke, which of those markers would be highly elevated to give us some information. The only one that where it was found to be really a significant increase is a D-dimer, but we know already from other cardiovascular or thromboembolic events the specificity of this is quite poor. So with regard to everyday clinical work, none of these measurements would probably be done in order to give us some information about an imminent risk in these in these patients, also not for the coagulation factors and also not for the endothelium. With regard to echo measurements, there are a number of parameters this can be assessed, and one you probably are aware of as well. Unfortunately, this is not a moving loop, but only a fixed picture. But you may see here this cloudy-like formation in the left ventricle. That's a hugely enlarged ventricle with a very poor contractile function. And if you see this spontaneous contrast or sludge, then you have an indirect and non-quantitative and sort of qualitative information that this prothrombotic state is actually imminent because you have some sort of impaired flow, increased hypercoagulability, and endothelium injury in these patients. There are a number of other variables in echo assessment which give you some information about the risk of coagulation. None of these, except the ejection fraction, none of these have actually been validated with regard to give us a quantitative assessment. So as a true biomarker, those are not helpful to give us a number like a normal range and a pathological range. Only reduced ejection fraction sort of gives us some idea that below 40 there is a significant increase in risk, where this number actually can be used. For all these others, it's basically to say if we see it, there is an increased risk, but it's not possible to put numbers to it. With regard to echocardiography, it's an important aspect I briefly want to touch at this moment. When I come to the stroke unit and I'm asked for the proper diagnostic workup, it's always, again, important to remind or to discuss with the stroke unit personnel to actually the pros and cons of the different echocardiographic techniques, because there is quite some, let's say, room to improve for the understanding of the capabilities and the limitations of a transthoracic and a transesophageal echo, because for the technical implications there, TTE has a longer distance and a lower resolution, but still you may identify certain aspects in a TTE which are not possible to see in a TOE. On the other side, with a TEE, you have a very short distance with a very high resolution at this short distance. So while you are not able to definitely exclude thrombosis in a TEE, but if you see them, then they are obviously there. You have, if you want to really make an exclusion, then the TEE has to be done. This is not for this is not mentioned to inform you. We know, our cardiologists know about this, but in the neurological world, I repeatedly need to discuss what you really want to see. Are you interested in wall thickness, in dimension of the left ventricle, or are you interested in the specific anatomy of a certain valve? And based on this consideration, then you should make the decision which of the two methods actually to use. Coming to the last in this format table, the last option, how to quantify risk of embolic coagulation, embolic events. That is the clinical implication, and for this, of course, we have a good score, widely used also in the guidelines. That is the CHETS-VAS score. It's the successor of the CHETS score. It has some more factors included here, particularly with age. We have now 2 compared to the CHETS score, and also sex category has been added, but it's still not the only one. There are more than just this one risk factor on the market. One criticism of this one is that it doesn't include renal function, and we know that renal function is one of the major factors contributing to the risk of embolic events. This has not been included here. Nevertheless, it's widely used so far, and therefore it's in the guidelines. There has been some addition or some adjustment in the use of this CHETS-VAS score in the most recent guidelines for atrial fibrillation. That is the borderline category of just one of this score is not related, or there's no recommendation whatsoever of aspirin anymore. So it's either coagulation or nothing, and this is new compared to the former ones. And this score is applied, or the application of this score is basically used only in patients with atrial fibrillation. And we have, because it's the major pathological condition where thromboembolism is a clinical problem, we have a huge amount of information how to deal with coagulation in the setting of atrial fibrillation, with persistent, with paroxysmal, with long-term, what the timing is, we have some data. However, if we go beyond atrial fibrillation, so other pathological conditions, we have far less information. For instance, heart failure patients with sinus rhythm. They have a large ventricle, they clearly have an increased risk of embolic events. Should or shouldn't we, those patients, treat with coagulation? Balancing again the risk between bleeding and thromboembolic events. There is far less information about the non-AF populations compared to the AF. Just one clinical trial I want to show you here on the heart failure with maintained sinus rhythm. Some years old already, it has been tested. Warfarin against Aspirin was found that there is no benefit. Despite the increased risk of cardioembolic events, there's no benefit because it's outweighed with the bleeding risk that is also increased with Warfarin. So the consensus at that stage has been that Warfarin is not a good option to treat those patients with regard to thromboembolic prevention. However, when this has been published, like 2012, it was just the time when the new anticoagulant treatments came around the corner, and basically all the information of the decades before we accumulated with regard to Warfarin need to be done now again with the new oral anticoagulant options that we have, particularly for patients like heart failure. This would be a tremendous addition to our knowledge. For the time being, we only have a large amount of knowledge for AF patients. And in summary, what I would like to put forward to you is that indeed coagulation is a principal underlying mechanism for ischemic stroke. We should understand that the three aspects are involved, the trias of blood flow, hypercoagulation, and endothelial injury, and those three are pretty much involved in all of the cardiovascular pathologies that we see regularly on the ward in our outpatient clinic. We do not have good quantitative biomarkers so far to actually in a quantitative manner predict coagulation. We have a clinical marker that is fairly applicable and very good, that is the Czech score. And of course, with regard to treatment, anticoagulation is an effective treatment. We know this for a long time with Warfarin. And with the new oral anticoagulants, we also have a better tool with regard to less monitoring needs and lower bleeding risks. So altogether, there is a need for providing further evidence of those new treatment options beyond the AF population. So when it comes to other cardiovascular pathologies, clearly there is a lot for us cardiologists to look at, to sort out, to find evidence with regard to stroke prevention. Therefore, it's really important that we as cardiologists get involved in this cross-link between cardiovascular disease and pathologies and stroke. And as you see here, there is an ongoing agenda that our Stroke Council has actually outlined, and we are enthusiastic to increase the evidence, but also the knowledge about this field. And you are just the first audience, or the one audience where we actually try to cross-link this between stroke and cardiovascular pathologies. And this is my last slide. Thank you for your attention.
Thank you very much, Wolfram, for excellent presentation. And there is an immediate question from Isabel van Gelder.
Thank you, Wolfram. Excellent presentation. I have a question. You told that blood biomarkers are not of help assessing the risk of stroke in patients with atrial fibrillation, but actually there have been those post hoc analysis, the ABC, BMP and troponin, can be of help. And you mentioned difficulties with the Czech. You mentioned that the renal function is not in it, but there's always the difficulties with the patient with Czech 1 or 2. Shall we start anticoagulation or shall we not start? And you have to discuss that with your patient. Do you then use those blood biomarkers? because that may then be of help, although not really incorporated. There are those Rheology trials.
I personally would not make the decision based on a BNP level when I'm just on this borderline limit of CHADS score of 1. I would go for the overall picture of that patient. But you are right, it is a should be treated decision that is given in the guidelines right now. So it still leaves us with some personal experience, some gut feeling, some feedback from the patient's interest, and we just need to wait for further data to make this gray zone smaller and smaller with the accumulating evidence. But right now, I would not make this decision based on BNP levels, for instance.